should be sharing. Yes? Okay. So without further ado, let me just proceed. I'd just like to give a quick overview on why childbirth is important for the Sustainable Development Goals and what it means for global health in general. Basically, there are over 140 million births that are occurring every year. That means there are 140 million contacts between a woman and her healthcare provider. And at this contact during childbirth, the degree and type of risk related to her labor and childbirth really does vary between countries and settings. And it depends on not only whether or not a health system is prepared, but it also depends very much on what the provider themselves knows about the best practices and most evidence-based recommendations that exist. While most births are occurring among pregnant women who don't have any identifiable risk factors, sometimes things can happen. And this is why all of us are trained to identify when things might be going a little bit more complicated than anticipated. And so this is where the time of birth is really critical to the survival of mothers and their babies, because obviously morbidity for the mom and baby and or mortality can increase considerably if complications arise and the healthcare provider that's present at the time of childbirth is unable to manage these complications. So why do we have guidelines? We spent a lot of time working on these guidelines. They are very big and thick, and they're there to provide for healthcare providers who are on the ground, really the recommendations and evidence on the what to do or what not to do kinds of statements. I want to say that as a former clinician, I am very sympathetic to the fact that nobody wants to read a 500-page document just to be told, maybe you should do this, maybe you should do that, consider this, consider that. We're trying very hard to make it clear if there is a do this or do not do this statement. It is up to WHO Secretariat to filter through all that information to present it in such a way that gives you quickly at hand evidence so that you know I should or should not do something. Of course, if you want the full details of everything, you can read the 500-page document, but they really are being produced in such a way that at a snapshot level, the casual reader of these guidelines or these recommendations should know what they can do, what they should do, and definitely what not to do, so that they can improve the quality of care at the time of birth and have the most impact to prevent any complications and to improve the outcomes. And so the guidelines are designed to be adaptable. We want them to be adapted into different settings, for them to be translated into different languages. And we're happy to be notified and can support where possible. But the idea is that for every context, every setting out there, there should be something that is taken from these recommendations that makes sense in that setting. I'd like to make the point that what I'm going to speak about today with regard to intrapregnant care, whether it be augmentation of labor or on induction of labor, that these are for recommendations that are for generally healthy individuals. They are within the documents themselves. There is some discussion about women who might have complications like diabetes, so on and so forth. I would like to make the point today that our recommendations on how to manage women who have pre-existing complications or other kinds of chronic conditions, those are coming out in the near future. We have other recommendations that deal with specific obstetric conditions like preeclampsia and what to do in the setting of hypertensive disease and preeclampsia. So those recommendations are slightly off topic today. I'm happy to take questions and refer you to the correct document. But what I'm going to be talking about today is for the usual run of the mill, as we would say, the general person who's come in, she's generally healthy. You haven't anticipated any complication for her because you haven't seen any risk factor for her. That's what I'm going to be talking about today. It's also important for me to mention, possibly at this point, that the guidance that WHO puts out is also meant to be woman-centered. That means that while we spend a lot of time talking about the quantitative evidence, or what does the research evidence show about any recommendation or any question that we might ask, the guidelines also include implicit and discrete consideration of what women want, what they need and value during childbirth. And so in general, it makes sense. Women want a positive childbirth experience that fulfills or exceeds their prior personal and social cultural beliefs and expectations. They want to do well. They want to go into the facility. They want to go in pregnant, and they want to be able to leave healthy with a healthy baby. That's what everybody wants. Healthcare providers want that, and the women want that. So the guidelines together put both of those perspectives, but I really think it's important to mention that the needs of the woman is really explicitly taken into consideration during our guideline discussions. And so what I'm going to go through now is sort of a movement of going from intrapartum care with specific focus on augmentation of labor, and then move on to some points for induction of labor. There are two documents that I'm drawing from, and they're on the screen for you here. The bottom one, which is the blue one, which is WHO recommendations for intrapartum care for a positive childbirth experience. This guideline includes several of the recommendations from the orange guideline, which is on top, which is augmentation of labor. And so I also want to recognize and acknowledge that I also, and we at WHO headquarters understand that it is sometimes difficult to know where to look for these different documents and recommendations. And we are in the process of trying to put together through software such as Magic App, so that it's easy for a general practitioner or somebody who's on the ground to know which recommendations can be put together and how can they be sure that they have the most up-to-date recommendation. And I will show you at towards the end of the my presentation how some things have changed. In general, recommendations that are provided by WHO say the recommendation. They say this is what you do or this is what you don't do. And then there are remarks that follow. So there's a box in the printed document which includes notations that the experts on the guideline development group felt you as readers needed to understand why the recommendation is being stated the way it is being stated. And so again, while we're very cognizant that it may be difficult to read through the entire guideline document, at the very least, if users can read the recommendation and the remarks, you should really be able to have in a snapshot picture what the recommendation is, why it's stated that way, and how best to implement it or put it into your context. So first, some overarching recommendations, and this is for any woman who's presenting for care. It goes without saying that respectful maternity care, which is organized for and provided to all women in a manner that maintains their dignity, privacy, and confidentiality, ensures freedom from harm and mistreatment, and allows her to have informed choice, decision-making, continuous support during childbirth is recommended. And this is for anyone, regardless if you have a low or high risk for labor complications, whether the woman is planning to give birth at home or a facility or hospital, regardless of who is there to help her, and regardless of what the country setting is. So I want to reiterate again that what we want to be able to make sure of is that women can go under childbirth in a space that maintains their dignity and that they are safe from harm and mistreatment. Now, part of that means that there's effective communication between the healthcare providers and the women. So, healthcare providers, please use simple and culturally acceptable methods and descriptions to describe what is going on, to discuss what is happening. So ideally, that kind of discussion and that kind of mode of communication has been in place since the woman has had antenatal care. But regardless of whether it did or whether or not this is the first time she is presenting for care, the communication between the healthcare provider and the woman should be in the most simple and respectful ways. And the next thing is, and I mentioned this on the first slide, is that a companion of choice is recommended for women throughout labor and childbirth. And this is somebody who is chosen by the woman to give her the support that she would like during labor. And it could be somebody from her family, her social network, it could be her spouse or her partner, it could be a family friend or relative, a community member, including any community healthcare workers, the doula. And it's also really important to mention that the woman's wishes should be respected. And it's possible that a woman may not want to have a companion. And so this should be permitted for her as well. We shouldn't force her to have somebody be with her if she feels safer and more content to be by herself. It's really going to be up to her. So with those parameters in terms of respectful care and need for good communication and support to the woman, I'd like to move towards what is it with regard to intrapartum care that might be particular with, have some particular considerations with regard to when is augmentation needed. So I think I'd like to spend a little bit of time here and say that one of the things that we at WHO and all of us looking at evidence need to be aware of is that sometimes things that happen in obstetrics happen because somebody said so. And it's only when you start looking deeper that it becomes clear that maybe what things that we took as truths are not always truths. And so one of the most, I think the biggest revelations that came when the labor care guideline was being written was that there's actually insufficient evidence to support the use of that partograph alert line as a classifier to detect those women who are at risk for adverse birth outcomes. So, first thing, if a woman has come in spontaneous labor, that threshold of cervical dilatation of at least 1 centimeter per hour during the active first stage, you know, that alert line that we're used to seeing, it's probably inaccurate to identify those women who are at risk for adverse birth outcomes. And so it's not recommended to use this. And that minimum of 1 centimeter per hour is also unrealistically fast for some women. And so just because a woman has cervical dilatation of less than 1 centimeter per hour, it should not be the indication that something has to happen. So the old adage, 1 centimeter per hour needs to happen, anything less, do something, needs to change. So the idea is, please recognize that, of course, every birth is unique, and labor may not accelerate or naturally accelerate until at about 5 centimeters of cervical dilatation has been reached. And so I've bolded it here, or highlighted it here, to make the case that medical interventions to accelerate labor and birth, such as oxytocin augmentation or proceeding to cesarean section before this threshold, is not recommended, as long as, of course, fetal and maternal conditions are reassuring. So please allow me to say that again. Use of interventions such as augmentation or moving to cesarean section before reaching 5 centimeters of cervical dilatation is really not appropriate and should not be done. We should recognize that birth and the labor acceleration for every woman is slightly different, and that we should allow that time for her to get to that takeoff point, as you can see in the graph at that top right of the screen for you, where it's about 5 hours that you can see the slope does go up tremendously. And so what I'm showing you here is, if we were to look back at that orange document, which is that augmentation document, I have blanked out that first recommendation that was in that orange document because it has been superseded by what I just told you. And that is, we should not use interventions or move to cesarean section before 5 centimeters of cervical dilatation has been reached. That said, we need to see if there is any delay. And so the recommendation that a digital vaginal exam every 4 hours should be conducted remains, okay? And so I think if you move down the process of, we need to first be very clear about whether or not the woman has delay in the first stage of labor. The only thing that is recommended there is a cervical exam every 4 hours. And it's recommended that you allow her to labor on her own until about 5 centimeters threshold has been reached. And that is when there is the presence of uterine contractions and cervical dilatation, showing that there is progress. Okay, so I just told you, you have to wait until 5 centimeters, until there's evidence of regular contractions, etc. Okay, let's say you have concern that the labor might be going slowly. I want to be clear then. Your concern is something that you tuck in the back of your mind, and you really have to hold your hands a little bit, because we're not recommending that you try to do anything to prevent delay. In other words, there's no recommendation for active management of labor. We do not recommend that you either give oxytocin or oxytocin with early amniotomy, or that you give an enema, or that you give antispasmodic agents, or that you give IV fluids for the woman to prevent any delay. We're also not recommending that you give pain relief to prevent delay and reduce the use of augmentation. In other words, please allow the woman to progress in her labor. And for those women who are at low risk, allow them to take in fluids and some food during early labor. Encourage them to move and sit up or be in the upright position if she is at low risk. And for everybody, allow her to have the continuous companionship as she is going through this first stage of labor. Okay, so again, the message, the overarching message is be patient, which I recognize can be difficult, and do not, there's no need to give any intervention to try to prevent any delay in the first stage of labor. Rather, allow the woman to be mobile, to be in an upright position, and to continue to have some fluid and food intake during labor with in the company of her companion. I want to just come back to the issue of pain relief during labor. Now, I did say that we don't want you to consider using pain relief to prevent delay and to reduce the use of augmentation. That's true. But it's also true that in the context of care, there might be a need for pain relief. And women will need to make or should be offered choices in terms of what kind of pain relief she would be accepting of. So for instance, relaxation and massage. There is good qualitative evidence that indicates that things like massage and relaxation techniques can reduce labor discomfort, relieve some of the pain, and of course enhance her maternal birth experience. Now, of course, you could move into more pharmacological methods like an epidural, which appears to be effective. But of course, we know that it takes more resources to implement either epidural or spinal anesthesia compared to parental opioids. But of course, even though parental opioids are widely available, they can make women drowsy, they can cause nausea and vomiting, and given very close to the time of childbirth, they can cause neonatal respiratory depression. And so there needs to be a balance of what is offered, and the woman should be made aware of all of these issues so that she can make her best choice in discussion with her healthcare provider. So I've just told you earlier, be patient. Don't overly give interventions. Wait until there's a diagnosis of a delay in the first stage of labor. Now, if you have found that there is a delay in the first stage of labor, then here is what is recommended. Yes, use oxytocin. Yes, use oxytocin with amniotomy if you have confirmed that there has been a delay in labor. But when you start oxytocin, the GDG wanted to make the statement that using a high dose of oxytocin and an increment dosage regimen is not recommended because there was no benefit for that. And the guideline development group also wanted to make a point that the use of oral misoprostol for labor augmentation is not recommended. And the reason that is because use of misoprostol in this context was being considered for lower resource settings where maybe there wouldn't be somebody who would be there to titrate the oxytocin. The GDG felt very strongly in saying, no, you should not use oral misoprostol because you cannot titrate oxytocin. Because if you cannot titrate oxytocin or you cannot provide that level of care, then you probably also cannot take care of complications that might occur with the use of oral misoprostol during labor augmentation. such as hyperstimulation, etc., which could lead to fetal distress. And so that is the thinking about why, if you need to augment labor, the ideal recommended intervention is either oxytocin or oxytocin and the use of the amniotomy. Also important to note is that the use of internal tokodynanometry compared to external monitoring solely for the aim of improving outcomes of augmented labor is not recommended. So if you have another reason to place an internal tokodynanometer, by all means. But if you're doing this only to see about your augmentation of labor, there's no recommendation to do that. So again, I'd just like to reiterate, if you do diagnose that there's been a delay in the first stage of labor, then yes, you should augment labor. And if you will augment labor, then what you should be using is oxytocin with or without amniotomy as necessary. And you do not need to use any internal monitoring for the purpose of your augmentation. Okay? So I've just gone through where you have allowed a woman to come into childbirth. You've been patient to see if her labor is progressing at its own pace. And if it's not after reaching a threshold of 5 centimeters and you've observed that there truly is a delay in her labor, you've gone on to augment her to move her towards childbirth, meaning the second stage of labor and ultimately to childbirth. Now, what about the cases of women who have not come in spontaneous labor, and you have you're not sure if what you need to do about inducing her labor? So permit me to move on to this set of recommendations and to explain to you that the recommendations have actually changed over time. So on the left side of your screen, you'll see that WHO in 2011 issued the first set of recommendations on induction of labor. And in 2017, it updated one of the specific recommendations, which had to do with induction at or beyond term. And that was published in 2018. And then subsequently, because of emerging evidence, that recommendations was updated again in 2022, as were recommendations related to the use of mechanical methods and or starting an induction in an outpatient setting. And so with this slide, I just want to share with you the fact that recommendations can evolve. Sometimes they can seem very similar, but what's happened is a guideline development group has re-looked at the evidence and has either reconfirmed or made a little tweak to some of the wording because of new evidence. And so what I'd like to show you here is that for a casual user or a casual person who's coming to the WHO website, you will see a web page like this, which shows that there is an update in the recommendation to a publication, and it tries to give to you the links for the different recommendations that might be related. In the middle of this page, you'll see something that says Web Annex and Evidence to Decision Framework. And it's, I'd just like to draw your attention that that Web Annex and that as Evidence to Decision Framework is in fact the bulk of all the evidence and all the discussion and the deliberation that the guideline development group undertook before making the recommendations. So if anyone is ever interested to read in great detail, you would read not only the documents, which is the guideline or the recommendation, such as as shown in the picture on the left side of the screen, but you would also go deeper into the evidence to decision framework. So a couple of principles on performing induction of labor. If you're going to perform an induction of labor, this should be done in a facility that can assess maternal and fetal well-being. Women who are receiving oxytocin, misoprostol, other prostaglandins should never be left unattended. In other words, You don't give her an intervention and leave her in a remote area where nobody is watching her progress. And wherever possible, induction of labor should be carried out in facilities directly where cesarean section can be performed. Okay, this is the GDG recognized that this may not always be possible, but this is the ideal. If you're going to do an induction of labor, then that induction of labor should be done in a space that is close or within where a cesarean section can be performed in the case of urgency. So, when is induction appropriate? I've again blocked out here the 2 recommendations that were superseded, and I'm going to show you those on the next slide, and then I'll come back to the other recommendations in terms of when recommendations might be relevant. Give me 1 second. So the first recommendation is that, sorry, excuse me. The first recommendation is that women who are known to have reached with certainty 41 weeks of gestation, induction of labor is recommended. And the second one is, and note the word routine. Routine induction of labor for women with uncomplicated pregnancies at less than 41 weeks is not recommended. So I'll just go back. What I've just read to you are the 2 recommendations that have been superseded in this box, and they are here now, okay? And so this is the 2022 recommendation, which is that you should wait until 41 weeks, so 41 and 07 days, and that you should not have routine recommendation less than 41 weeks. However, I want to bring your attention or draw your attention to the fact that the GDG made specific comments on timing. So the first is, I mentioned that the woman should have met with certainty 41 weeks. So it's important to recognize that the WHO additionally recommends that 1 ultrasound scan before 21 weeks of gestation. So an early ultrasound is recommended for all pregnant women to estimate gestational age and to improve detection of fetal anomalies in the case of multiple pregnancies, and to reduce the risk that there might be induction of labor for a post-term pregnancy that was not actually post-term. The use of 41 weeks, again, was debated, but most women will give birth by the end of the 41st week. And so allowing spontaneous onset of labor will minimize interventions and the potential for over-medicalization of a physiological process, which might lead to a more positive birth experience for the woman. Now, I mentioned the second recommendation, which used the word that routine induction at less than 41 weeks gestation should not be used. The reason the GDG worded the recommendation in that way was because the GDG did note that there was evidence from a large study from a high-income country that noted that there was a modest level of perinatal benefits for low-risk women who underwent induction of labor at 39 completed weeks. That is, there was a small reduction in the need for cesarean section and the numbers of perinatal morbidity. But the GDG recognized that those findings may not be generalizable to lower resource settings. And so what the GDG felt compelled to say was that if a woman between 39 and 41 weeks with her provider and in the context of their values and preferences, understands the risks and the benefits, that if labor induction can be carried out safely, then it's something that can be discussed, and that this kind of joint decision making should begin very early during antenatal care. So I'll just repeat this again. In settings where induction of labor can be carried out safely, So going back to the principles, which is primarily cesarean section can be carried out where, I'm sorry, induction of labor can be carried out where women can be monitored. They are attended at all times, and cesarean section can be conducted in the case of need. And you have skilled providers, of course, where you're able to provide midwifery care, fetal heart rate monitoring, and access to pain relief and immediate access to cesarean section. That in these circumstances, in the context of the woman's values and preferences, and in discussion and in joint decision-making with the healthcare provider, an induction of labor between 39 weeks and up to 41 weeks gestation can be considered. So that's two ways of looking at that recommendation that says, on the one hand, you're not going to do this routinely at less than 41 weeks. But if the woman has reached 39 weeks and you've had this discussion and you can manage all the things that I've just mentioned in terms of care provision, then this can be discussed. Now, induction of labor obviously can increase the use of resources. So you need to use the induction agents, you need health workers, you need facilities. And so if you're going to do this, then there should be a very specific clinical indication documented or state that the induction of labor was undertaken at maternal request. So because induction of labor risks inadvertent prematurity, moving towards other kinds of complications, or even the need for cesarean section, we should be cognizant of that. And we should need to document why that induction of labor was being done in the first place. Regardless of when a woman goes into labor, or if you decide that you're going to induce her at a certain point for post-dates pregnancy, high quality antenatal care and of course fetal surveillance should always continue until that point. And again, just to reiterate, these recommendations pertain to women with uncomplicated pregnancies. So I'm not talking about the women who have anything else like preeclampsia and so on and so forth. Now, if you decide that a woman should undergo an induction of labor, then a couple of things here to note. Oxytocin can be used. Oxytocin with a balloon catheter can be used. Oral misoprostol is recommended, okay? Or vaginal, low-dose vaginal misoprostol is recommended. But misoprostol is not recommended for women who have had a previous uterine scar or cesarean section. I want to draw attention to the fact that the two recommendations on the left-hand side of your screen, number 12 and number 13, they were superseded by the two that are on the right hand of the screen, which very much say the same thing. It was just here again that the GDG wanted to relook at the evidence that was available. But factually speaking, the recommendations stayed the same. So to reiterate, use a prostaglandin. If they're not available, use oxytocin. Use amniotomy by itself is not sufficient and not recommended for induction of labor. You can use oral misoprostol 25 micrograms every 2 hours, or you can use low dose 25 micrograms vaginal misoprostol every 6 hours in women who do not have a prior uterine scar or a prior cesarean section. And you can also consider use of a balloon catheter or a balloon catheter plus oxytocin. You may want to consider these in situations in particular where the use of prostaglandins or misoprostol might be contraindicated. Like for instance, those women who've had a prior scar. A couple of other notes. In the third trimester, in a woman with a dead or a non-OLS fetus, you can use oral or vaginal misoprostol. And sweeping of membranes is recommended for reducing the need for formal induction of labor. So in your late third trimester visits, you can consider doing sweeping of the membranes. Now, of course, during induction of labor, one of the biggest risks of induction of labor is uterine hyperstimulation. And if that should happen, you do want to proceed and use beta mimetics. And the last thing I'd like to bring up is outpatient induction of labor is not recommended for improving birth outcomes. Again, this was a recommendation that was re-looked at and republished in 2022. And this was re-looked at because there were studies that were looking at induction of labor in a home setting. And so again, the GDG did note that in some settings, and I would be curious to know if this would be even the case in Myanmar, that some women who are at low risk can be offered outpatient induction of labor and get to the hospital in good time if they live near the delivery facility. That this might be, again, a situation where this could be considered, but this is certainly not something that is going to be recommended on a routine basis. So I'm nearing the end of my formal presentation, and before doing so, I'd like to just say that, again, the recommendations that I presented today to you are the conglomeration of a guideline development group's assessment of a lot of information. So not only the evidence of effects, meaning quantitative effects that one might view related to the intervention, like in a cognitive systematic view or any kind of systematic review on the effect of intervention, but it's also taken into account the values of preference of women, as well as their healthcare provider. So it's looking at both sides, as well as the acceptability of whatever intervention there is for the healthcare provider to give it, and for the woman to accept the intervention, the feasibility of that intervention's use, which includes consideration of resource uses and costs, and whether or not that intervention would increase equity or even sometimes decrease equity, because sometimes interventions can actually, by access to that intervention or unequal access to an intervention, actually result in making larger inequities. With regard to implementation, and I think this is where it's very critical to understand, and I'd love to hear feedback on what it's like on the ground for you in Myanmar. The idea is to put the guideline into context and to allow for countries and settings to put it into wording or put it into a sense that is implementable in your space. And so this is really at individual recommendation level. But ultimately, we have to consider that while on the left-hand side, we can update clinical guidance and we can develop or revise guidelines, protocols, or job aids for intrapartum care. And this is something that would often be done in conjunction between WHO, our Geneva offices, with our regional and our country offices. Ultimately, on the ground, settings need to make sure that the health facilities are equipped not only with supplies and resources, but certainly the people who are there to provide the recommended practices. And sometimes this actually means changing our behavior and being able to support that behavior change. So I would say, just looking ahead, you know, when the recommendation came out that said you can throw out your old partograph that use those 1 centimeter alert lines, that requires behavior change, and that requires a lot of change in terms of printing out of documents, teaching, mentoring, and really changing how we do something. So we know it's not easy, and that's why it's important to have trainings, technical support, and engaging different stakeholders that can help support that behavior change. It's hard to change what you were taught to do. We all know that. But as evidence comes forth, one of the most, I think, important things to recognize about all of us is that we are agile and thinking people. And that is why we can change our behavior and we can do better once we know that there is better. So the WHO Interpartum Care Model, which is going back to that blue book that I showed earlier, it is meant to be implemented as a package of care. And it is really, it works when it is delivered by kind, competent, and motivated healthcare professionals who have everything that they need. And so the couple of principles that are important to reiterate as we get towards the end of this presentation is that labor and childbirth should be individualized and woman-centered. No intervention should be implemented without a clear medical indication. And I've gone through a couple of touch points on this. And only those interventions that serve as immediate purpose or that are proven should be promoted. And the objective really is that there's a positive childbirth experience for the woman, the newborn, and her family. And that is really the essence of why we're all here. I know that every single one of you wants that. And I know that every single one of you have felt times where it's not always easy to do that. And this is where we have to push the paradigm, and we have to push the health system to make sure that as healthcare providers and as professionals in this space, we can do this for the women. And this means that organization of care needs to be reconsidered. And we obviously have to anticipate that there will be changes in infrastructure, human resources, and the availability of health information. And so part of all of these recommendations and thinking about what it is that is needed to actually implement these recommendations is to identify where is there a lack of human resources with the necessary expertise and skills? And if there is, what can we do to remedy that? Is there a lack of infrastructure to support the recommendation practices like physical space for a labor companion? Do the facilities have the supplies and the medications that they need? And can the health information systems actually document the recommended practices? I mentioned that it is critical to document why an induction of labor is being undertaken. If there's nowhere to document that, we will never find that documentation. And ultimately, we will never be able to move forward programmatically. And so, this is an urgent plea that from the very, very basic infrastructure, where can I document? How can I document? Is that documentation being moved into a system that is robust? Do we have space for people? Do we have a space for providers to do their work? And do they feel comfortable? Are they empowered to do their work? And do they have the expertise? Have they been given the training that they are and the knowledge that they are expected to be able to deliver? I think it's also a question of integrity for all of us who are at training levels to make sure that we impart on our trainees, on our mentees, the knowledge that they need to have to actually be able to implement the recommendations that I've just mentioned to you here. This is my last slide, and that is to say that the Maternal Perinatal Health Group of WHO, we have a living guideline approach to guideline recommendations, and that is we're constantly looking, we're surveilling the evidence and the literature to see if there is new evidence that might change recommendations, in particular those that were do or do not do kind of recommendation statements that were only based on what was considered low quality evidence, or where evidence was not necessarily generalizable. For instance, if evidence only came from high income countries before, and now we have evidence from low and middle income countries, we should put that into the evidence base and relook at that evidence base in the context of the recommendation. And so the other thing is to mention that we do recommend that if you have any questions that you think should be relooked at or looked at for guideline level statements, what we call normative statements, please then send them to us. And every year we go through and we look to see which ones can be considered. And really anybody can send in these kinds of statements or questions to us. And with that, I thank you very much for your attention, for your interest, and for all the care that you provide to the women in Myanmar. And I thank you for your collegiality and your support as we move through and get through our global health agenda. Back to you.